patient. So all the soft sounds will be amplified more than needed, and the patient will hear high ambient noise that is continuous all the time. So as you see, the complaint of the patient may reflect the problem. So if the patient doesn't hear the soft sounds, so you may need to increase the T levels. Or if the patient is complaining of high ambient noise all the time, so you may need to decrease the T levels for him. Now we go to the upper stimulation level, or the C level, or the most comfortable level. Here in cochlear software it is represented by the red dots. انا بحاول اشرح على one software عشان يبقى الفكره واضحه للكل يعني، بس يعني انا هستخدم اكتر cochlear للتوضيح. So what happens if we set that C level lower than needed? C level is very important to hear the loud sounds. So if we set the C levels at a lower than needed for the patient, the sound will be compressed, and this decreases the speech recognition, producing poor sound quality, and even the patient will not be able to monitor his own voice. He will not hear his own voice. On the other hand, if we put the C levels at a higher level than needed for the patient, this will produce overstimulation, and the patient will not be able to tolerate the sound. This will produce discomfort and poor sound quality. And if we did this in a child, he will refuse to use the device completely, even if we have C level higher than needed, even in one of the channels, not all the channels. And I have many patients that the C levels were adjusted at a higher level and they refused using their device, and I spent maybe more than 1 month to adapt them again to use their devices after reducing the C level. So how can we measure the T and the C level of the patient? As you do in the hearing assessment, we have subjective tools and objective tools. When we need to do hearing assessment for a patient, we can do pure tone audiometry or speech audiometry, and these are subjective tests. And if we need to do objective way, we can measure using the ABR or the autoacoustic emission or any objective tool. Similarly, in the T and C level measurements, we can use subjective or objective measures. So what are the subjective measures? To determine the threshold or the T level, we have the subjective or the behavioral responses similar to the pure tone. So we can ask the patient to raise his hand when he hears the sound, or do any signal that I can know that he is hearing the sound clearly. Or in children, we can use play audiometry or behavioral observation, or sometimes also we can use visual reinforcement like the free field. So we need some toys to attract the attention of the child during the session of programming. And as I mentioned before, assistant is very important to check the responses of the child while doing the programming process. Another way to measure the T levels, which is using the loudness scaling chart, and here we can use it in adults or in older children. And in this situation, the child or the patient will point to the level of the sound, and we can detect the threshold from this way of measure. If the patient is having false positive responses, for example, due to tinnitus, and he gives many false positive responses, we can ask the patient to count the beep or to move his hand with the stimulus to detect the false positive responses in the patient. So as you see, usually the measurement of threshold is difficult, especially in the early fitting session or in the switch on session, because the patient's not used to the signal yet, and especially if he is having long duration of hearing loss. Also, we may face difficulties in tinnitus patients due to false positive responses, or in uncooperative and young children. So in this case, we can use some of the objective tools to help us in doing the programming. Now we go to the C level or the comfortable level, and how to measure the C level of the patient. First, we can use the loudness scaling chart, and the patient will point to the loudness till we get the most comfortable level for the patient. In children, if the child is very young and cannot point to the loudness scaling chart, we can use a different technique. I prefer to use the global increase of the C levels. هنا يا جماعة بعد ما بظبط ال C level بحط ال C over the T نفس الوقت، يعني عليها بالظبط السي والتي يبقوا زي بعض. بعدين ببتدي اعمل لايف اكتيفيشن اوف ذا ديفايس، اسمع البيشنت الصوت من بره من السراوندينج، وبعدين هبتدي ارفع السي ليفلز at all electrodes at the same time مع بعض، والصوت شغال والبيشنت سامع، وبحدد كده اذا كان في comfortable response ولا لا. في نقطة كمان مهمة بعملها بعد ما بقيس السي ليفلز، ان انا بعمل sweeping. يعني ايه sweeping؟ يعني I can stimulate each electrode at the C level or at the comfortable level. ليه بعمله؟ To check if the patient is tolerating the sound or not. Because as I mentioned, if we have overstimulation even at one channel, this will be disturbing to the patient and he may refuse his processor. Another important point in the adjustment of the C level is the loudness balancing. What I mean by loudness balancing, that the patient should hear all the sounds at equal loudness when I stimulate him at the C level. يعني بالعربي كده، يعني أنا مش هلاقي فرق في اللودنس ما بين channel والتانية، لازم كلهم يبقوا مظبوطين إنه كلهم مثلا على الموست comfortable level they have the same loudness. ليه؟ Because this will help the patient to identify the relationship between different parts of the speech segments so he can understand speech correctly. طبعا ده بيبقى صعب في الأطفال، بس ببتدي أعمله لما بيكبروا شوية ويبقوا cooperative. So as I mentioned, we meet many difficulties during these behavioral measures, and maybe the child is uncooperative or very young, or even in adults sometimes we find difficulties, especially during the switch on and the first time programming. So we need to use some objective tools for assessment. So what are these objective tools? We can use electric stapedia reflex, the ECAP, or the electric ABR. So first of all, the electric stapedia reflex threshold. As you do the reflex threshold measurement by tones, we can apply it using electrical stimulation. So we can stimulate the electrodes, each electrode at high current level to elicit reflex from the other ear. We connect the patient to a tympanometry device to record the stapedia reflex, and we give stimulation through the processor at different electrodes. And we reduce the current level till we get the threshold for this electrical stimulation at each electrode. This is example from the software. So we stimulate at high level and go down till we reach the reflex threshold. And I adjust this reflex threshold at each electrode. And from studies, this stapedia reflex threshold is correlated to the C level of the patient, or the most comfortable level. So if we know the stapedia reflex threshold, we can adjust the C levels of the patient close to the ESRT levels. However, in some situations, we are not able to record the stapedia reflex, especially if the patient is having middle ear problem, for example, or bilateral implant, so we cannot depend on the stapedia reflex threshold. So we have other tools like the ECAP. What is ECAP? It is a compound action potential measurement by electrical stimulation. This is the response of the auditory nerve that we can elicit, similar to wave 1 in ABR, but by giving current stimulation, and it can be recorded easily through the telemetry function that is available in all the cochlear implant devices. We stimulate the patient electrically at different electrodes. This is example from cochlear. We stimulate electrode number 22 at high current level to elicit the response. Here the response is very clear. It is formed of single peak, and we go down, reduce the current gradually till reaching the threshold. So here we detected the threshold at electrode number 22, and then we detect the threshold and more other electrodes in the middle or the near the base of the cochlea to have the full configuration around different channels. This is example from software of Medel and the example from Advanced Bionics. If we know threshold of the ECAP, this is here the blue dots are the threshold of the ECAP. From studies, this threshold is present in the upper part of the dynamic range, closer to the C level. So if we know these thresholds, we can set the T and C levels around this ECAP threshold. And we make the C level closer to the ECAP. And I can use low levels at first and then I start to increase them gradually to avoid overstimulation. Another way to measure the T and C levels is the electric ABR thresholds. Here we record the electric ABR, the ABR for the patient through evoked potential system, but by stimulating the electrodes by electrical stimuli through the cochlear implant device. And we elicit here, this is an example from our patients. These are the electric ABR waves, and we stimulate and go down to threshold and detect the threshold at each electrode. Also, from this threshold, we can find or adjust the T and C levels because there is similar correlation, like the ECAP and the electric ABR threshold also lies in the upper part of the dynamic range. So we can set the T and C levels around the electric ABR threshold. But it's very important to know that if you depend totally on the objective tools and doesn't use any behavioral measures, this will not get the best benefit or the best map for the patient. And you have to apply some behavioral measures or subjective measures and to get clear response from the patient in addition to the objective measures. طيب عشان اشرح النقطه دي هعمل case presentation. This patient was referred to me. She was implanted outside our center and in Saudi Arabia, and she was using the device for 1 year. She was around 3 years old, and the patient didn't have any benefit from the device, and the parents reported that she doesn't respond to sounds. I checked her map and I found that the map was done objectively, totally. They depended, the person who did the programming depended on the NRT or the ECAP thresholds, and the programming was based only on the ECAP. And when I checked the ECAP response for the patient, I noticed that the patient gave responses at higher levels than that was set for her. The threshold, her T level was higher than was set based on the objective tool or the ECAP. So I did behavioral adjustment for her, and I depend mainly on her behavioral responses, and I got a map that was different from the first map, the objective map, especially in the lower frequencies or in the apical regions. And she started to give me clear responses even during the session of the programming, and later on she showed marked improvement. So you cannot depend on the objective tools alone, and you have to apply some behavioral measures to help you in addition to these objective tools. So given the important role of optimal map for speech perception and the fact that the map cannot be based only on electrophysiological measures, it should be noted that the maps of very young children who cannot be conditioned for play audiometry should be monitored periodically until reliable behavioral thresholds can be obtained from the child. طيب after finishing the stimulation level، طبعا احنا بنظبط الستيميليشن ليفلز دي في الفيتنج سيشن او في السويتش اون، وزي ما قلت لكم في السويتش اون ما بتبقاش الاكيوريت ادجستمنت، واحيانا بندي البيشنت لو ليفلز عشان تو افويد اوفر ستيميليشن، لان في بدايات الفيتنج بيبقى مش متحمل اي صوت عالي، فبندي lower level than needed. عشان كده بنعمل فولو اب كلوز فولو اب after 1 month to readjust، وبعد كده بنعمل فولو اب every 3 months. كل 3 شهور بنعمل hearing assessment to check the hearing of the patient and the speech recognition or speech testing, and we decide if we need to do readjustment for these stimulation levels or not. So in each visit, the main adjustment will be focused on the stimulation levels of the patient and the configuration of his map. However, sometimes we need to change other parameters, not only the stimulation levels. So I will talk about these other parameters in details. First is the coding strategy. Regarding the coding strategy, it is different for different companies. Coding strategy means the way of transmitting the sound to the electrodes inside. How these sounds will stimulate the electrodes inside the cochlea. It is different in different manufacturers, and usually we set the coding strategy to the default of the software, and we do not change this coding strategy. Another parameter is the pulse width. What is pulse width? Here, this is example, and this graph shows you these are the electrical pulses that stimulates the electrodes inside the cochlea. If you use wider pulse width, this is narrow pulse width and the upper one is wide pulse width. If you widen the pulse width, you will be able to stimulate greater area in the basilar membrane and to stimulate more spiral ganglia, so we can elicit better thresholds with wider pulse width. So when we increase these pulse widths, I usually use the default of the software, but in some situations I need to increase these pulse widths. This is an example of these situations. If you find the thresholds or the T levels, the green dots, are very high in the patient and the dynamic range is very narrow, so we can use wider pulse widths to decrease these T levels and get better thresholds and get better dynamic range to enable the patient to hear different aspects of speech. Another example, sometimes this is in cochlear software, you find this picture, the C levels reached what's known as saturation level. So the electrodes are out of compliance here. We have to reduce the C levels for this patient, but we will get narrower dynamic range. So in this situation, we can use wider pulse widths to improve the T levels and to improve the dynamic range for the patient. Another indication of using wider pulse widths is the electrode array design. We have mainly two designs, the contour or the modular electrodes that is applied close to the modulus in the cochlea, and lateral wall electrodes applied laterally on the lateral wall of the cochlea. So in lateral wall electrodes, they are away from the modulus, so we can use wider pulse widths to stimulate more spiral ganglion. And this usually is set automatically by the software. Now we go to other parameter, which is the stimulation rate. Stimulation rate means the number of pulses that will stimulate the electrodes per second. And the stimulation rate is usually set to the default of the software, and this usually suitable for the separation between the electrode contacts, and so we do not prefer to change this stimulation rate. And if we increase the stimulation rate more than needed, we may get undesirable interaction between channels, and this will be perceived as high-pitched sound or tinnitus, and the sound will be of poor quality. So we do not prefer to increase the rate of stimulation over that is set by the default of the software. However, in some
دكتور نترين لو سمحتي بس I'd like to remind that إن فاضل 4 دقايق، لو خلصت الوقت هنبدأ إن شاء الله ميتنج بعدها على طول نفس الاي دي ونفس الباسورد.
يعني هنكمل على طول مش هنقطع؟
ممكن نكمل على طول، لو قطعت هنبدأ بنفس الاي دي ونفس الباسورد.
طيب خلاص.
اتفضل.
طيب indications to decrease the pulse rate. For example, in patients of auditory neuropathy, cochlear nerve deficiency, or old patient, because the nerve is usually slow or may have fatigue. So to avoid this fatigue, we can decrease the rate of stimulation. But I do not use it regularly. I have many auditory neuropathy patients, and I use decreasing the rate in only few of them. So it's not commonly used, but in case we need to decrease the rate, we can try to decrease the rate and to check the performance of the patient. Now we go to the frequency allocation, which is one of the parameters present in our softwares. Here, what is frequency allocation? It is the frequency response of each of the electrodes implanted inside the cochlea. And in different companies, we have the apical electrodes that are usually gives response to lower frequencies, and the basal electrodes are stimulated by the higher frequencies. And usually this is set to the default of the software, and we do not change it. And even if we closed the electrodes for any reason, closed some electrodes, the frequencies will be redistributed on the remaining channels, and rarely we can manipulate it manually. This is an example of one of the patients who had history of trauma, and we had open circuit at many channels, and we closed these channels, and the frequencies were redistributed to the remaining channels. The last thing is the channel gain. What is channel gain? It is an acoustic feature of the processor. It's the amplification of sound or the compression that happens before transmitting the sound or converting the acoustic signal to electrical signal. Similar to what happens in the hearing aid, we can control this gain or we can control the compression ratio to the sound, and this usually I use this only if I cannot manipulate the C level of the patient. If the patient is complaining that the sound is too muffled or too soft and I need to increase the C level, but I reach over stimulation, so we can try to increase the gain of his processor. So as I mentioned before, the most important is
دكتور نسرين بأكد تاني بس إن لو الميتنج قطع دلوقتي بعد 6 seconds هنكمل إن شاء الله. أوكي؟ أوكي اتفضلي. إن شاء الله في questions اتفضلي يا دكتور.
طيب أوكي. دلوقتي ده as I mentioned before ان ال stimulation levels هي اهم حاجه، يعني انا في اهم حاجه وهي اللي بتعمل great effect على الماب هي ال stimulation levels اللي هم T and C levels and they should be adjusted accurately. انا دايما بقول ان احنا لو انت audiologist شاطر وبتعرف تعمل pure tone كويس وبتعرف تعمل assessment للبيشنت كويس، هتقدر تعمل adjustment لل T وال C levels بطريقه مظبوطه behaviorally. طبعا we can depend على ال objective tools بس زي ما قلت قبل كده ان ال objective tools alone are not enough and we have to depend on these behavioral measures. And as I mentioned in rare situations بنقدر نغير ال pulse width أو ال pulse rate ودول أكتر حاجة ممكن نعمل لهم manipulation. طيب في كل سوفت وير جزء بيقول لي how to deal أو how to solve different problems. هنا مثلا in cochlear this is the hearing mentor. هنا بيحط لي مثلا if the patient بعمل search على البروبلم بتاعت البيشنت. For example if he is having all sounds are the same، هنا بيديني شوية حلول، مثلا اعمل balancing أو check the mic check the sensitivity، يعني بيديني شوية حلول نقدر نستخدمها لما بنبقى beginners في البروجرامينج، لأن في الأول احنا طبعا الاكسبيرينس بتاعت البروجرامينج بتتاخد من البيشنت، لأن كل بيشنت ليه مشكلة لوحده وليه حلول مختلفة، يعني مش نفس الحل في كل يعني لو نفس اتنين عندهم نفس المشكله ما بيبقاش نفس الحل. فدايما باخد الاكسبيرينس، كل ما اشوف بيشنتس اكتر كل ما اشوف اقدر اتعامل مع مشاكل اكتر اقدر احلها. في البدايه ما بكونش شفت بيشنتس كتير بقدر استخدم الجزء ده من السوفت وير اللي بيساعدني في الاول، بس بعد كده بتمرن ايه المشاكل وايه الحلول المختلفه بتاعتها. So to finalize, the ability to maximize the full potential of a CI is dependent on an optimal programming, and a poor cochlear implant program equals poor cochlear implant performance. كده أنا خلصت يا جماعة، معرفش وقت الأسئلة أو هيبقى في second meeting. Thank you.
دكتور نسرين احنا مكملين، يعني لو حد حابب يسأل يتفضل.
يبقى كده لو في أسئلة، بس لحظة واحدة أنا محتاجة أشغل. أيوة
اتفضل.
اوكي لو في اسئله. اوكي انا كنت سريعه شويه بس لان حاسه الوقت يعني.
يعني يا ريت لو حد حابب يسأل يتفضل يبعت للشاتنج أو raise hand and I will open his mic. شكرا جزيلا دكتور نترين لحضرتك، شكرا جزيلا لجميع الزملاء. اتفضل دكتور أحمد.
دكتور نسرين شكرا جدا. سامعاني دكتور نسرين؟ دكتور نسرين؟
دكتور احمد احنا سامعين حضرتك، مش عارفه دكتور نسرين. ثانيه واحده. ميتنج قفل. اتفضل دكتور احمد.
شكرا جدا دكتوره نسرين، شكرا دكتوره فاطمه، شكرا لكل الزملاء اللي حضروا. ان شاء الله يعني مستمرين على كده. دكتوره نسرين ادت محاضره قيمه جدا جدا، وباذن الله هنكمل، وبدعو الدكتوره نسرين تاني محاضره تانيه تكمل ان شاء الله، نرتبها في وقت تاني عشان الزملاء يستفيدوا. شكرا دكتوره فاطمه، وان شاء الله كل يوم ثلاث باذن الله.
ان شاء الله.
ألف شكر دكتور احمد، الف شكر بجد، يعني انا سعيده جدا بالميتنجز دي، وان شاء الله اتابعها كل اسبوع. والف شكر يا دكتوره فاطمه، وشكرا على مجهوداتكم الجميله جدا في التنظيم. وربنا ان شاء الله يسهل ونقدر نعمل تاني برزنتيشنز اكتر يعني.
نسعد بوجود حضرتك دايما دكتوره نسرين، ودايما معلوماتك وخبرتك قيمه وكلنا بنستفيد منها.
ميرسي، ربنا يخليك. ربنا.
شكرا لحضرتك، شكرا لكل الزملاء، شكرا ميرسي لحضرتك. العفو، مع السلامه.
مع السلامه.
مع السلامه.